Welcome to the St. Vincent Evansville and University of Evansville Neurologic Residency Program presentation. My name is Megan Bretz and I am the Program Director. I will be leading you through this overview today. Ascension St. Vincent Evansville, formerly known as St. Mary's, was founded in 1872 by the Daughters of Charity as the region's first hospital. In 1999, the Daughters of Charity National Health System and the Sisters of St. Joseph Health System came together to create our new national health system, Ascension Health. Ascension Health joined with the Carondelet Health System in 2002 to expand Ascension Health's geographic presence in 24 states and the District of Columbia as an advocate for the uninsured and the underserved. Over the years, more Catholic health systems have joined Ascension Health, and our mission is featured on this slide. Additionally, as part of the Ascension Ministry, we're called to service of the poor with reverence, integrity, wisdom, creativity, and dedication. The University of Evansville's mission statement is to empower each student to think critically, act bravely, serve responsibly, and live meaningfully in a changing world with core values of integrity, innovation, intellectual curiosity, inclusive community, and education for the whole person. The mission of the University of Evansville Physical Therapy Program, founded over 40 years ago, is to provide doctoral level education to prepare students for autonomous and ethical physical therapy practice. With careful consideration of the mission and values of our collaborating organizations, we developed our own program mission, which can be read on this slide. With this mission, we envision continued organizational growth and identification of St. Vincent Evansville as the premier provider of neurologic rehab services in southwestern Indiana. Our program goals are as follows. The program will support the mission, vision, and core values of the sponsoring organizations, provide sufficient opportunities through direct patient care for the resident to develop advanced skills as a clinician across practice settings with a variety of adult and geriatric patient populations. The program will provide the Ascension Healthcare Ministry with residency-trained neurologic physical therapists who excel in the areas of clinical practice and leadership. The program will demonstrate sustainability. And finally, the program will graduate physical therapists who demonstrate a continued commitment to professional growth and development. Our resident goals are as follows. The resident will demonstrate advanced skills in neurologic physical therapy practice as a direct provider in the comprehensive examination, evaluation, and treatment of neurologic patients in a variety of practice settings. The resident will demonstrate advanced skills as an educator, utilizing appropriate educational strategies consistent with both the setting and the needs of the learner. The resident will demonstrate leadership through service opportunities to promote prevention, wellness, and overall health of the local community. The resident will demonstrate leadership through research at the organizational, local, state, or national level to promote the profession of neurologic physical therapy. And finally, the resident will be prepared to sit for and successfully pass the American Board of Physical Therapy Specialties Board Certification Examination in Neurologic Physical Therapy. Our residency is divided into 5 main components, which include patient care, didactics, teaching, research, and community service. The remainder of the presentation today aims to provide the answers to the most frequently asked questions about our program, starting with, what do the practice rotations look like? The residency will begin in the acute care setting. The resident will spend 10 weeks here, working with a wide variety of neurologic patients, including neuro-ICU and trauma. At the conclusion of the acute care rotation, the resident will transition across the street to the 24-bed Rehab Institute. This is actually where the bulk of the residency takes place. At this practice site, the largest neurologic patient population is stroke, followed by traumatic brain injury and spinal cord injury. Here, patients receive a minimum of 2 skilled therapies and participate in a minimum of 3 hours of therapy, 5 to 7 days per week. The final practice setting is outpatient rehabilitation at the Ascension St. Vincent YMCA, and this clinic is located within the YMCA, opening up into the common wellness area. This clinic was opened in September of 2019 and was intentionally designed to meet the complex and comprehensive needs of the neurologic patient population. Many pieces of specialty equipment exist here, including bodyweight supported treadmill training, virtual reality treadmill training, and functional electrical stimulation cycling. The entire gym is covered in bodyweight support capabilities to offer either unweighting or serve as a safety catch during therapy sessions. In addition to managing stroke, brain injury, and a growing spinal cord injury population, this site also markets to the neurodegenerative patient populations. Each practice rotation consists of a series of skill checkoffs and live patient assessments to ensure competency before moving on to the next level of care. How is the mentoring structured? So before we talk about the structure of the mentoring, I want to introduce the clinical mentors. In the acute care setting, we have 2 clinical mentors. Sherilyn Rust is a 2015 graduate from the University of Evansville. Sherilyn is a stroke rehabilitation specialist, certified clinical instructor, and an adjunct faculty member in the doctoral physical therapy program at the University of Evansville. Jenny Hsu is a 2004 graduate from the University of Evansville. Jenny specializes in management of our trauma population, including brain and spinal cord injury. She also is a certified advanced clinical instructor. In the rehabilitation setting, we have 4 clinical mentors. Shannon Dixon is a 2016 graduate from the University of Evansville. Shannon is a stroke rehabilitation specialist and a certified clinical instructor. She is a mentor in inpatient rehab. Mary Wagner is a 2011 graduate from the University of Kentucky. Mary is board certified in neurologic physical therapy and also a certified clinical instructor. She is a mentor in inpatient rehab. I am a 2001 graduate from the University of Evansville. I'm board certified in neurologic physical therapy, and I also am a certified clinical instructor. I'm an adjunct faculty member in the doctoral physical therapy program at the University of Evansville. In addition to being the program director, I primarily mentor in outpatient rehabilitation, but I also help out in inpatient rehab as well. Finally, Hannah Lamar is a 2019 graduate from the University of Evansville. Hannah was our first resident, successfully completing this residency program in August of 2020 and earning board certification the following year in 2021. In 2022, Hannah joined the faculty full-time in the doctoral physical therapy program at the University of Evansville, but Hannah does continue to mentor in inpatient rehab. Residents will have the opportunity to engage with all 6 clinical mentors throughout their program year. The residency requirement is that a resident engages in 1,500 hours of direct neurologic patient care over the course of the program year. Of those 1,500 hours, a minimum of 150 hours must be mentored. Our weeks are structured so the resident engages in about 32 to 36 hours of direct patient care weekly, of which a minimum of 4 hours are formally mentored. Our most recent resident graduate logged 1,561 hours of patient care, of which 346 hours were mentored, so she averaged closer to 7 hours per week. Regarding mentoring specifically, this occurs in person, it's one-on-one, and is individualized to meet the specific needs of the resident and the scenario. Formal mentoring is scheduled weekly as a collaboration between the resident and the clinical mentors, which is based on many factors, including the availability of the patient, the mentor, and the resident, as well as the complexity with the patient case. Approximately 2/3 of mentored sessions are resident-led, which means that the resident is the primary driver of the session, and approximately 1/3 of mentored sessions are mentor-led, which means that the mentor is the primary driver of the session. Resident-led sessions allow the resident to develop his or her own skills with the guidance and feedback of an expert clinician. But the value of mentor-led sessions is not to be underestimated, as learning is also facilitated by observing the skills, techniques, and patient interactions that occur with our expert clinicians serving as the primary care providers. Additionally, we set aside time every Friday morning to reflect on the previous week and set goals for the upcoming week. This is a testimonial from our current resident, Paige King. Paige states, mentorship was a huge component of residency that drew me to the program. The acute care mentors are immensely knowledgeable and experienced in their practice and have so much to offer a PT resident. The mentors always offered constructive feedback and enhanced my learning and skills as an acute care therapist. The weekly mentoring worksheets were helpful as well as the daily feedback forms and the mini assessments. These tools offered multiple opportunities for me to receive written feedback and grow within my practice. I like having the monthly goal sheet as I like structure and clearly defined expectations. Second question, what's Acercise? So ACE Care is an organization founded and run by the University of Evansville Doctor of Physical Therapy students as a solution to the growing need for healthcare services among the most vulnerable in our community. ACE Care provides an incredible opportunity for students to expand their skills and social awareness under the supervision of local licensed physical therapists who volunteer their time and expertise to make a difference in Evansville's most vulnerable pediatric, adolescent, adult, and geriatric populations. ACE Care has 3 branches, ACE Plus PT, ACE Buddies, and Acercise. ACE Plus PT is an outpatient PT clinic that serves community members who are underinsured, uninsured, or homeless. ACE Buddies serves children and young adults with special needs in a group-based setting. And Acercise serves adults with neurologic diagnoses, which is also delivered in a group-based setting. All of these services are completely student-run at no cost to patients or participants. Our residency program is involved with the Acercise branch, which is delivered in a group format 2 nights a week. Our resident serves as both a mentor and a supervisor to the Thursday evening classes. Third question, can you explain how the didactic component works? Sure. Our residency program partners with the Institute for Knowledge Translation to deliver the didactic portion of our curriculum. Chris Henderson serves as the Director of Innovation, and Jenny Moore is the founder. Both Drs. Henderson and Moore are heavily involved with national and international research and knowledge translation efforts around locomotor recovery following stroke and motor and complete spinal cord injury. I also have a role with the Institute for Knowledge Translation facilitating some of the group mentoring sessions. The didactic curriculum is comprehensive, including educational modules on a variety of neurologic conditions and treatment approaches. The curriculum is fully accessible on August 1st, 1 month before the clinical component begins. A schedule of coursework completion is provided with consideration for the clinical rotations, the typically encountered patient populations, and the Monday night mentoring topics. A unique component of this curriculum is the Monday night mentoring meetings, in which the resident will join other neurologic residents in their respective Midwestern residencies to engage in group mentoring and discussion around various topics and activities. I've included a snip of our Monday night mentoring schedule for January and a screenshot of a recent January meeting. Sub-discussion topics include critical appraisal of relevant research, with each resident summarizing and presenting a section of the paper to the larger group, or discussions with leading scientists and researchers on their respective work fields, or group discussions on various case studies provided by the residents and the meeting facilitators. Residents typically spend a few hours on the weekend preparing for the Monday night meetings and are expected to contribute meaningfully to the discussion. The degree and depth of contribution changes throughout the course of the residency year. As the resident grows in knowledge, confidence, and experience, contributions to the group discussion are also expected to expand and deepen to reflect this growth. Finally, IKT does administer our final residency examination in July, which is a 200-question examination that mirrors the rigor and comprehensive of the NCS examination. Next question. The research component is unique. Can you explain this part a little bit more? Sure. So the goal around the research component is that the resident completes a case study and makes a meaningful contribution to a knowledge translation project or a formal research study at either Ascension St. Vincent or the University of Evansville. The case study component is pretty self-explanatory. We require that this case study is written up and submitted to our program, and if desired, it can be submitted to a conference. Our first resident elected to complete a case series on the successful application of high-intensity gait training interventions post-stroke and the subacute stage during the inpatient rehab stay. She submitted her abstract to the Indiana APTA Fall Conference, and she was selected to present in poster board format the following fall. Our second resident completed a similar case series, submitted it to the ANPT Fall Conference, and she was selected to present in poster board format as well. The second part of the research component is a little more unique. The resident may elect to jump onto a current research study or contribute to a current implementation project. So, what kinds of projects have been completed? Recognizing the important training parameter of intensity, our first resident identified a gap in practice around continuous heart rate monitoring. In collaboration with myself, she identified that less than 25% of all sessions post-stroke in inpatient rehab were monitored for heart rate response. Through a series of knowledge translation interventions, she was able to increase clinician compliance with continuous heart rate monitoring to over 86% in just a few months. Although not a direct goal of our project, we also found that treatment sessions were beginning to prioritize walking interventions overall. This practice shift appeared to contribute to grossly improved functional outcomes at discharge. Since that time, our second resident has expanded this project to include knowledge translation interventions to maximize the amount of walking practice that our patients post-stroke engage in on the unit. This project was also successful, with a 12% jump in treatment days when patients met their individual stepping targets as measured by ankle-based step accelerometers. Both of these projects have been since rolled into formal performance improvement projects, which means that they're being monitored on a much bigger leadership level now. Our third resident brought these two projects together and helped to lead meaningful team discussions on every fifth patient that discharged from the unit post-stroke. This required a comprehensive retrospective chart audit on heart rate response, stepping totals, and functional outcomes of each of these patients. The research component is often the most unnerving to residents. Rest assured that the decision-making around all of these options, as is the execution of the final project plan, is heavily mentored and should be based on what the resident feels that he or she can best contribute to, given his or her skill set and interest. Next question. I've never taught before. What does this component look like? Our resident begins the teaching component in January, about 5 months into the residency program. The resident serves as one of the Thursday morning lab assistants for the neuro rehab course that exists in the spring semester of the second year of the University of Evansville doctoral physical therapy program. This program is delivered at Stone Family Center for Health Sciences, which is located in downtown Evansville. The campus is about 6 miles from the main hospital and just a few blocks from our outpatient clinic. The resident will also be responsible for delivering a single lecture on a topic of choice or leading a series of smaller classroom discussions. The resident will attend the weekly planning meetings prior to the Thursday lab, where clear expectations around the resident role and responsibilities during each lab will be identified. Many residents end up pursuing a career in academia. Our first graduate did, and this teaching component serves as a foundation to developing those skills, with Hannah Lamar serving as the mentor here. All of these components, direct patient care, didactics, other educational opportunities, teaching, research, and community service, comprise our program. The residency standard is that participants engage in 1,500 hours of direct neurologic patient care over the course of the program year, with a minimum 150 of those hours mentored. This past year, our resident logged 1,561 hours of patient care, with double the amount of required mentoring at 346 hours. Residents are required to log both the medical conditions encountered in all practice settings and the functional outcomes after treatment in the inpatient and outpatient rehabilitation settings only. In collaboration with the Institute for Knowledge Translation, our residency provides a comprehensive tracking log for recording all of this data. The second residency standard is that the participants engage in a minimum of 300 hours of education. Our program exceeds this standard. Actually, we double it when factoring in the didactic work, the educational opportunities, the research, the teaching, and the specialty observations. With our curriculum, we easily meet and exceed the expected 1,800 program hours at over 2,100 hours. So this is a lot, right? How does this even fit into a typical week? Let me show you. So this is an example of a typical week in the early spring during the inpatient rehab rotation. Monday morning starts with a DPT faculty meeting, followed by a full day of patient care. The resident jumps onto a 90-minute IKT mentoring meeting that evening, for which he or she has spent a few hours preparing for the weekend prior. Tuesday and Wednesdays are full days of patient care, with about 90 minutes allotted for mentored patient care mixed in somewhere. It's pictured here in the early afternoon, but that's completely flexible. It is suggested the time on Wednesday evening is allotted for didactic work, research, or preparing for lab the next morning. Thursday morning from 8 to noon is spent in lab with the second-year DPT students. The afternoon is spent on more didactic work and research. That evening, the resident serves as a class supervisor and mentor to exercise from 5 to 7. Friday morning includes a weekly mentoring meeting with the program director and the primary clinical mentor, utilizing a structured worksheet to encourage self-reflection and formal feedback on successes and areas for improvement. Goals and action plans for the upcoming week are identified at this time. The remainder of Friday is patient care, with about 90 minutes allotted again for mentoring. A little bit of time on the weekend is allotted for didactics and preparation for the Monday night mentoring meeting. For candidates who are unfamiliar with Evansville or even Indiana itself, there may be some hesitation to relocate to what is perceived to be a small city in the middle of nowhere. While Evansville is not a booming metropolis, it is the largest city in southern Indiana and the third largest city in Indiana after Indianapolis and Fort Wayne. Tucked in the southwest corner of the state along the Ohio River, it is very close to the neighboring states of Illinois and Kentucky. For that reason, you will hear this area referenced as the tri-state. Evansville is appealing to many because of its hometown feel and its low cost of living. Another perk of living in this area is that you're literally a weekend trip away from many larger cities. You could be in Indianapolis in 3 hours, Cincinnati in 3.5 hours, Louisville in 2 hours, Nashville in 2.5 hours, and St. Louis in 2.5 hours. So for those that like the energy and the atmosphere of the big city but don't necessarily want to live in it, Evansville is a great place to call home for a year, or for some of us a lifetime. I will leave you with one final testimonial from Sam May, who is our 2022 graduate and current stroke team lead at Vanderbilt. On top of it all, the different components of the residency are also very special, working through the entire continuum of care, teaching experiences, research experiences, community service experiences, and collaboration with numerous different clinicians and medical team members, shadowing experiences, and just the general exposure to a wide range of neurologic diseases and diagnoses. You don't get all of that in many other programs. I also appreciate the passing and benchmark goals that are set for the resident, the weekly meetings in addition to the quarterly meetings and rounding, and the constant open line of communication to really ensure the resident knows exactly how he or she is doing and what the expectations are during each phase of the residency program. And this concludes our presentation. Thank you for your interest in our program and for your future efforts, wherever they may be, to enhance the evidence-based care of this amazing neurologic patient population. You may reach out to me directly with questions at any time, either through email or phone. Thanks again.